for the Dr. Farooq Abdullah Award Oration. And our guest orator for today is Dr. Frank Ferris, who is the Associate Director, Hospice and Palliative Medicine Education, Ohio Health, Columbia, USA. We extend a heartfelt welcome to you, sir. May I now request all the dignitaries to kindly grace the dais. Our guest orator for today, Dr. Frank D. Ferris, our Principal and Controller, Dr. Rajiv Bagahatta, ADP Academics, Dr. Monica Jain, and Dr. Ashwin Mathur, PhD Palliative Medicine. May I now request our Principal and Controller to extend a floral welcome to our guest orator. Thank you, sir. I would now request our Principal and Controller, Dr. Rajiv Bagahatta, to deliver the welcome address.
Good afternoon, everybody. Welcome our distinguished guest, Dr. Frank D. Ferris, my colleagues, seniors, and students. Nothing could have been more appropriate, more in place than the topic of today's oration. In fact, when I was going through the curriculum vitae of Dr. Ferris, I realized that palliative medicine includes everything. And to that end, I am not surprised that he has got his main work into internal medicine and radiation oncology. A few years before, we could not have imagined that there would be one specialty which would be including all other specialties into its domain. And palliative medicine is one such thing. I was just discussing with Dr. Frank regarding the awareness about this particular stream of healthcare and regarding the hesitation which the treating clinicians have about this particular stream. Needless to say that today's oration will not only make us more aware about this particular domain, but also give us insight about treating those patients where palliative medicine can be the only hope to take care of these patients. With these words, I welcome you, sir, and thank you for being part of our celebration. Thank you, sir.
Thank you so much, sir. May I now request Dr. Ashwin Mathur, Professor and Head Department of Palliative Medicine, SMS Medical College, to formally introduce our guest orator for today.
So, very good morning to all dignitaries on the dais and off the dais. It is my personal pleasure and privilege to introduce Dr. Frank Ferris, who is currently the Associate Director, Hospice and Palliative Medicine Education, Ohio University. Dr. Ferris is known globally as a trailblazer, a visionary, and an innovator in palliative medicine research and education. Don't waste your time being angry at the nursing home. Put your energies into activities that will make the world a better place for those living. His mother's words, after his father's appalling death experience, became the grounding compass that continues to frame his palliative and hospice care manifesto and core values. He has been recognized with a Golden Jubilee Award by Queen Elizabeth II, has received a Canadian and American Leadership Award, and has n number of publications, research and projects to his credit. A clinician par excellence, He has authored many books which palliative medicine specialists swear by. Dr. Ferris has also been the driving force behind the International Palliative Medicine Fellowship Program, which I too have had the good fortune of attending and achieving. He has been instrumental in bringing a paradigm shift in transforming the deplorable conditions of patients and their caregivers and improving their quality of life. Your contribution, sir, to this field of palliative medicine shall always be cherished and honored. I invite you to benefit us all by your oration on expanding horizons of palliative care. Thank you.
Everything okay? Yes, perfect. What an honor to be here with all of you and to share this afternoon. I'm going to ask you all to reflect. You're not going to be passive. I'm going to ask you to think about your practice in healthcare. I have nothing to declare, and again, I always share everything I produce. If anybody wishes to take the slides and use them, you're welcome to. Let's start out with a brief video. This was created by Moonshine Movies in Melbourne, Australia. The reality is, we have a crisis in our world today.
When you open your eye in the morning, there's nothing but pain. When you sleep, there's nothing but pain.
People do not understand the issue of pain control.
80% of the people who died last year died in needless pain.
This is a real crisis. Pain affects everyone, some more than others.
Ideas should be having more and more people to go for the pain meds. We don't have any time to know. If not for the medicine. It's much easier to think about dying.
There is a crisis in the world today. Over 600 million will suffer organs.
It's cheap. There is no excuse for not making this accessible.
War on drugs will never end.
The use of prescription drugs for legal purposes is increasing, especially increasing in our youth.
Some of the PRs that deal with cancer, that deal with, painful diseases, and they look at you like you're a drug addict.
We have more emergency room admissions for aspirin overdose every year in the United States than we do for heroin overdose.
We know that it's not a matter that we need to invest a lot of money inventing new drugs. We haven't. The problem is, from a pharmaceutical company standpoint, there's no money to be made.
Unrelieved pain is torture. It doesn't have to be like this.
You're in pain, you're dead to the world. In fact, I believe that relieving the pain is preliminary to good palliative care.
Dying is not a medical event, it's a human experience.
We know she's not going to be cured, but we fight to have as long as we can, and we fight to have as good time as we can. You don't want to leave him. Yeah. That's the most painful thing to think about.
Live well. Die better.
And we all have the right to die with dignity and in peace and pain free. Unfortunately, the reality is that that's not the case.
I'm happy that you still have hope. I know that you're out of the bit, but I'm happy.
I'm just learning.
For someone who's facing end-of-life issues, really, if we were to focus on death, there is only one type of death. There's nothing much that you can do about death. But if we were to focus on life, and that's powerful.
I want to go on living medication with the doctor's help. I'm okay.
The question before us
So you focused on learning the best of medicine. In fact, the success of modern medicine is unprecedented. Since penicillin became our first antibiotic just at the end of World War II and became widely disseminated, and we began to deal with infectious diseases, today we do things so differently. And you just described a story to me of a colleague having a thrombectomy and other interventions which even 10 years ago wouldn't have been thought about. Do you practice evidence-based medicine? Who puts up their hand and says, I practice evidence-based medicine? And I'm asking you to put your hands up. Nobody in the room practices evidence-based medicine.
All of us.
Oh, well, but I want your hands up. I want you to show me your hands, please. I really want you to be active today. So are you focused on curing the disease or controlling it? Are you focused on prolonging people's lives? Who would say, I'm focused on fix it and prolonging people's lives? Yes, come on, truth out. I know the focus of medical schools all around the world. It's disease management. And yet, what's the reality? Do you want your patients to live longer? Yes. Who would say yes? I want my patients to live longer. Yes, okay. It's my thesis today. So what brings your patients to your healthcare system? Do they walk in the door and say, I have a disease? Or do they walk in the door and say, I have a symptom that's causing me a problem and I'd like help to fix the disease and the symptom? I suspect for most of us, people walk in the door with a symptom, don't they? And what do they have as expectations? That I'll manage that symptom quickly. But they want to live longer, almost all of them, just like you. So what's the percent of your patients who arrive with advanced disease? How many would say, well, it's about 20%? I'm going to ask you to put up your hand for the number. How many would say it's about 40%? How many would say it's about 60%? 60%. How many would say it's actually up about 80%? So again, with people with advanced disease, what are we able to do becomes the question I challenge us with. Because of course you and I can do anything, can't we? But if it's all about life, are we really empowering somebody's life? Or are we doing things that are actually causing harm? It's my challenge for you. Joan Tino, sorry, not Joan Tino, your colleagues, just drawing a blank on the name for the second, published this paper on the 4 patterns of functional decline. There's the organ failure, and you're the specialist in cardiology. You know how it goes, right? The patient arrives, we have a crisis, I can get them better, can't you? Then they come back again and again. Are these the frequent flyers? And suddenly there's sudden death. Or there's the cancer story. First line therapy, second line therapy, and because of the new immune therapies, this might go along for a long time, and then we start to see decline. And when performance status starts to deteriorate and we don't have other therapies, we know prognosis is limited. There's the dementia story, the new success story of modern medicine. Did you ever think it was a success story? It absolutely is, because it's about living longer. How many people in the room would like to imagine living to be at least 85? Who would like to live to be 85? Well, half of you who put up your hands will have dementia. Isn't that a joyous story to think about? Or maybe there's the, I'm doing okay and I fall asleep and I die in my sleep. The sudden death. These are the 4 trajectories. It really doesn't change. It was Joanne Lynn who published this data, I'm sorry. But what turns out is because we have markedly prolonged the lives of people living with advancing illnesses, and often today in North America, you can expect to have 3, 4, even 5 major diagnoses. Isn't that going to be fun? I'm starting to live with that. You have the disease, but you have the physical issues that cause you suffering, those symptoms you arrived with. Are you able to move around as well as you were before? What about fluids and nutrition? You have the anxiety, the distress, maybe depression. You have family concerns, the social dynamics, spiritual questions, the need for care, clearly the end of life experience, and then the realities, which are the grief when families lose someone they love, and the transition of that huge change in our family dynamics. And of course, it's not just about the patient, is it? It's about the patient in the context of a family experience. I understand that is even greater here in India than in my world. The reality is, the family lives with the decisions we take. They experience the treatments, they provide the care. Some of the caregivers actually lose their careers. They often pay for the patient's care. We know in our society about a third of families go bankrupt in the process, and we have health insurance. What's the story in India? And of course, everybody remembers the decisions taken, and the reality is everybody in this room, you're all watching your own future, because we will all get sick and die. We're human. It's our reality. Now, does this ever happen in India? That families resist telling patients the truth? Yes. Does this ever happen here at SMS Medical Center? The families rush in and say, do not tell mother. Yes. Do not tell father. Right, why are they doing that? They're doing it because they love the person, they want to protect them. There may be spiritual and religious perspectives, but they're worried that the words will harm the person, and they're afraid of loss. When this happens to you, do you ever sit down with the families and have the conversations to really understand why they're making those choices and call out those realities? In a family meeting, I will say, you love mother very much, and you really want to protect her, don't you? And you're afraid she's going to die, or you're worried about harming her. And then I get a flood of tears. Everybody says, well, he really understands us, doesn't he? And then the conversation can really begin about, well, what would mother like? Now, of course, there's the reality of sometimes it feels uncomfortable to tell a patient the truth, doesn't it? Who would say, yes, I have that experience sometimes. I feel uncomfortable telling the patient the truth. It's about communication skill training, isn't it? And did any of you have a mother who said to you, if you can't say something nice, don't say anything at all? Yes, did your mother tell you not? So of course you sit there saying, well, I don't have something nice to say, I better not tell them. And yet, we know that the majority of people are planners. They've got things they want to achieve, and they need to know. And if they don't know, and they miss doing the things they're trying to achieve, they may be angry with us because we didn't tell them. So there's two sides to all of this, and I realize many of you would say to me, oh, Frank, you don't understand India. It's different in India, and I'm going to say to you, oh, dear friends, you don't understand rural Ohio. It's not different because the people came from wherever with all those perspectives. This is worldwide. And this issue for doctors and nurses and counselors is universal. But we need to get past this. We need to learn how to convey this. It turns out we've done studies in multiple cultures, and the majority of people want to know. Not everybody. So if you had an advanced illness, would you want to know? I'm asking you, put up your hand. Would you want to know? So not everybody in the room is what I see. We need to find out. So we've talked about uncontrolled symptoms. Can you imagine that uncontrolled symptoms will actually impact prognosis and shorten people's lives? The data is really clear. The answer is yes. And if you're interested in people living longer, you gotta manage the symptoms as well as the disease. We know the chronic pain. People don't move, they don't think, they don't eat well, they have anorexia, they don't sleep well, they get insomnia, and they get high levels of stress, poor mood, and they're often depressed and withdrawn. And the reality is, when you unwrap the story, they lose their capacity to work, they lose the capacity to do the things that are pleasurable. They often have fluctuating emotions and tensions. They often become dependent and need care, and they may well die faster. I'd like you to meet Bill, a real patient I saw in the island of Cyprus. Started out with prostate cancer, 3 years later had metastatic disease, and just like the gentleman in the video, when I asked him what his pain was like and what it would be like if it was not controlled, he said, excruciating, unbearable, and oh my God, life would not be worth living if it's not controlled. Can you imagine a life where you can't do the things you like to be able to do? How about you? And how about you? Because you're in pain, or you're short of breath, or maybe you're nauseated, you're weak and fatigued. It's important. Also meet Martha, a woman with advanced pulmonary fibrosis. When we met her, she'd had it for multiple years. It came from smoking. Dyspnea at rest, worse with any movement. She was a shopper. How many of you ladies like to go shopping? Who likes to go shopping? Come on, confess up. And you couldn't go shopping, or you couldn't go get your hair done, or you couldn't go get your nails done? Oh, exactly. She couldn't do any of it. And she came to your emergency room 21 times in the last 24 months. What's the emergency room doctor saying about her? And I'll promise you, she has adhered to the treatment recommended by her pulmonologist perfectly. So why does she come? Well, she gets up in the morning. By mid-afternoon, when she's starting to move around, she gets short of breath. She calls her primary doctor. Their office is already full, and the message is go to the emergency room. There's nobody prepared to respond to her shortness of breath in the community. Or meet Ellen, the dean of a nursing school, University of Pittsburgh, for a decade. She also develops acute pulmonary fibrosis, a different cause, no therapies to help her. She moves to Columbus, Ohio to be close to family. By the time we're asked to see her, her shortness of breath is so extreme that she's sleeping 18 hours a day to avoid the experience. She's had marked weight loss, and my colleague projected that she would live 2 to 4 more weeks. Would you like this to be your story of how you finished your life? So short of breath, you have to escape into sleep, and you're using pharmacology to help you sleep. Or maybe it's this story of ovarian cancer. It's her husband in the middle, an emergency room physician from our healthcare system. Marin presents with a complete ovarian bowel obstruction. She's had treatment at one of our National Cancer Institute certified hospitals in Columbus, Ohio. She's been vomiting and nauseated for the last 3 weeks. They haven't provided the symptom management, and she admits herself to our hospice for end-of-life care. And the video, which you're welcome to watch on our website, tells the story. I'll come back to all these stories in a few minutes. So the uncontrolled symptoms, the anorexia, the insomnia, the poor function, the loss of stress, patients live poorly, and it's very clear they die faster than they should. So those of you who are in the team to fix it, and I want you to fix me as much as possible, I want the symptom management as well, because I know it's going to help me live longer. It's a part of excellent palliative care, is focusing on that, focusing on the communication, making sure we have good decision making. So how many of you would say, well, I'd like to live like those patients? I don't see any hands going up. We all want something better, right? And of course, I'm going to come back to the success of modern medicine. You absolutely needed to focus on disease management, particularly in India, where you had high rates of infectious disease as well as non-communicable disease rates going up now. It was a great place to start, but now we have an opportunity for you to go further, just as we've been going further. So what is this palliative care? You already saw in the last video, Balfour Mount, a urological surgeon who himself developed Hodgkin's lymphoma, treated with radiation therapy now about 35 years ago, who actually has developed his second primary in his esophagus, also treated, still alive today, many years after that primary treatment. He and I will share with you, and he's the original pioneer who coined the term palliative care. We'll share the story briefly of what's palliative care.
One of the things we want to bring around the end of life is dignity. We want people to die with dignity and quality of life. If you talk to anybody who have lost a loved one, the greatest regret people have is that I wish I said goodbye. I wish I spent 10 minutes with my dad and told him how wonderful he was. And I regret that personally because my dad passed away in great pain. His pain was not controlled, so he died in a lot of pain. And there was no opportunity, he could not even comprehend who was there with him when he died. And I think that is a regret for all of us. When we lose our loved ones and in so much pain, they are wailing and screaming, they do not even know you are there. So it's just providing that dignity and an opportunity for people to put their business in order. Because at the end of life, your value as a human being does not stop.
Many people ask, what is palliative care? I see it simply as therapeutic interventions to try to relieve and even prevent issues that cause suffering.
Palliative care is whole person care.
To try to avoid pain, or when it starts, to manage it well, to deal with many other symptoms that I might experience.
It takes seriously physical, psychological, social,
anxiety, depression, challenges within my family,
existential, spiritual, financial issues.
Spiritual questions. Why me? Where's God? What about the meaning and value in my life?
It recognizes the profound importance of Sisling's term, total pain.
To help me manage the advancing illness as I approach the end of my life, to help me prepare for the end of my life, and specifically to manage all of the issues that arise during the dying process so that I can feel as comfortable as possible and have a safe transition as I die.
Whole person care is a central concept, but the foundation of the edifice of whole person care is excellence in physical care, good nursing care, good, knowledgeable, available medical input. This is not a place for amateur night. These are the sickest people in the healthcare system. They deserve the best care.
Between the hospice people and my doctor and the others, the nurses, specialists, they've turned me around so that I can sit up and I can, it's a marvelous thing.
Thanks to them, we when she is comfortable. And when she's comfortable, we can laugh and joke and have meals together and just kind of treasure this time together. And without them, it would probably be a much different situation.
We have this wonderful profession of hospice and palliative medicine that is an international profession, and so people don't have to go through this alone. That there are experts that can help them to walk through this, and that people do not have to die in pain.
In an age where we're doing such wonderful things in all specialized areas, to then bring amateurism to the sickest people in the healthcare system, it's ridiculous, particularly when we know how much that we can achieve, how helpful we can be.
So we can utterly be helpful, and we can take that next step of bringing palliative care to India. It's an opportunity. This is new knowledge, new skills. We are frequently at the level of receptor affinities when we talk about treatments today. It's no longer simply the art and the love that Dame Cecily Saunders brought. She thought about the pharmacokinetics. This morning I was teaching the pharmacokinetics and everybody in the room had forgotten them. It's about evidence-based medicine in this realm. My goal is to prevent and relieve your suffering at the outset. I want you to have the best quality of life even in the face of illness. I want to make sure you die safely and comfortably, and I want to look after your families. And while this started in the world of cancer because the profoundness of the suffering is unbelievable, this is about for patients with any diagnosis. You're quite right. I've incorporated my best of medicine in everything I do. I might go see a patient with congestive heart failure. The next patient has cancer. The next one has amyotrophic lateral sclerosis. And then I come back to somebody with pulmonary fibrosis. It's my day. And then there's dementia. And it's for any time there's a need. And what do I mean by that? Well, I'm focusing on symptoms, and there's a small list up there, but there are many symptoms. We teach effective communication skills, how to deal with that challenging family, to make sure that the person who wants the news gets it, and the person who doesn't want to know doesn't find out. There's strategies for all of this. And then there's the difficult decision making, isn't there? Your colleague that you described today is facing endless ventilation, or am I going to be able to stop the ventilator because I can see that there's no value, that this person will never again be the person that they would want to be. They will never have the life they would want to have. In India, you're about to change the rules at your Supreme Court level, and this will become much easier. We routinely stop and don't even start therapies that are going to be harmful. Of course, there's the dying and there's the grieving. I'm not wanting to minimize them. They're very much a part of what we all do. There's a real science to managing the dying process. Typically hours to days to a week or two, when people are really changing. Our goal, in the simple terms, and this is what I say to family in the street, is to help people eat well, sleep well, maintain their function, and reduce their stress. I know they will live better. I also know they will live longer. And we've got story after story after story. So this started in 1960s as the modern hospice movement with Cecily Saunders. Today, I'm going to say it's a little different. Yes, we start out with the anti-disease therapy, the end of life that she described, and the bereavement support. That's a part of the illness, and of course, all of you are focused on the red zone, the management of disease, and you teach that at SMS. I'm going to challenge you to go a step further. We've learned in randomized controlled trials, this is the Temple study from the Massachusetts Hospital in Boston, that early palliative care provided in contrast to conventional care. Although it was done to look at symptoms, the patients lived 3 months longer on median survival. Now, how many of you would like your patients to live longer? Yeah. So this is metastatic non-small cell lung cancer. This has led our American Society of Clinical Oncology to say that all patients, inpatients or outpatients with advanced cancer, should receive dedicated palliative care services early in the disease course, concurrent with active treatment. So this isn't about and or, this is about together. How can I help you be successful? And it doesn't necessarily need to be me that does this. I can teach you how to do all these things as well. And then when it's complex, you can call me. Because I'm, as you are the cardiologist, I can do basic heart failure management, but when it gets into really tough, I need your help. It's the same as other specialties. It's also been demonstrated that quality of life is better. You can see the hospice, that's our system in the United States for advanced palliative care. It's a special benefit. Not only was the care rated by families, and it's a large study, better than anywhere else, it turned out that they got better pain relief, they got more physician contact, and they got respect in the hospice setting. Or look at what was happening in the hospital. They couldn't find a doctor. The doctors wouldn't come to visit. Why? Because their mothers told them, if you don't have something nice to say, don't say anything at all. And they didn't know what to say. So they avoided going in the room. These are the sickest people in our population who want us to visit. They're desperate for at least us to hold their hands, and they weren't going in the door. Now, of course, this is also a new medical specialty, recognized in the United States in 2006 by 10 of our 24 parent boards, not only internal medicine, but surgery, pediatrics, emergency medicine, rehabilitation, psychiatry, neurology, I could go on. And we have a one-year fellowship, and it's recognized by your National Medical Council here in India with 10 colleges offering training, and you're one of them, right? You have a training program right here. Fabulous. We also have multiple professional journals and textbooks today that are highly recognized. And the World Health Assembly has said this needs to be care for everybody. So this is an opportunity for India, isn't it? It goes back to the primary care level, which is what the World Health Assembly says. We need to be able to care for people close to home, but of course it starts in your center right here. And then as you send people home, we need to make sure they're going to continue to get the good care. Because isn't that what you want for yourself? I suspect so. So I'm going to suggest a different model. The approaches to palliative care start right out when the patient walks in the door with those symptoms. An integration of managing the symptoms that come because they've got the disease, but also managing the symptoms that come because you're giving them treatments that are toxic. It starts day one. We also know that in the success of survivorship, we're now seeing about 15% of the patients in our outpatient clinics who are survivors because often the treatments are devastating. I have one young executive, he was leading a corporation. He was treated aggressively for his cancer. He has been cured to the best of our knowledge, but the neuropathies and the other dysfunction that came, he's no longer able to work, and he has constant pain. Debilitated, but he's going to survive for years. And of course, there's the advanced suffering that goes on with advancing illness, that difficult decision making. Do you really want this treatment or not? Is it really going to be helpful? Honest communication. Of course, the end-of-life care and the bereavement support for patients and families. It's about palliative care now being integrated throughout people achieve their life goals. I want to ensure that therapies are beneficial, minimum risk, and minimum burden. And of course, in your setting, the issue of money comes up all the time, doesn't it? Because the risk of us pushing therapies that may not really be helping the patient is bankruptcy. And I've already said we see that in America regularly. I can imagine that's true in India as well. People spend their family savings because out of love and the desire to protect and the fear of loss, they don't want their loved one to die. It's natural. Wouldn't you feel that way about your partner? Or maybe it's your mother or your father, or maybe it's your child. Now, what becomes important is for us to also begin to recognize when therapies are not helpful and may even be harmful. On Sunday, we're going to have a session and talk about that, particularly focused on fluids and nutrition and antibiotics, because sometimes antibiotics are simply prolonging the inevitable. And of course, then there's ventilation. The challenge for India, and hopefully your Supreme Court will put in place opportunities for you to say, when it's really now being harmful, we can stop it. Let's see where it goes. So every single person in this room can provide palliative care. I'd love the opportunity to teach all of you the core skills and the knowledge, and of course, you, sir, the cardiologist, the oncologist, the pulmonologist, people seeing more patients with more suffering. I'd like you to give you some of the advanced skills. And then of course, here you are in your specialty training program, teaching the experts. And you begin to provide services in all settings where patients receive care. We at Ohio Health have integrated consult services in 8 of our 12 hospitals, a specialty unit. We're in our long-term care facilities. We have several ambulatory outpatient clinics, and we have a very large patient program at home, covering an entire geographic area that is probably 10 or 12 counties in size. How will you be the leaders to develop that? So, how does this work? What's the value? I'd like to share some more stories and come back to the others. I'd like you to meet Kit, a colleague of mine. She came to work with us, and she had to have a routine physical exam and an x-ray, and she had a large mass on her x-ray. She was feeling terrific. Probably cancer. She says right from the outset, I want the best possible care, and I'm clear I want to be comfortable, and I'm clear she was coming to a new work. I want to be able to work. She had a subtotal pneumonectomy. The pathology was adenocarcinoma. The metastatic workup showed no evidence of cancer. The oncologist could not find the primary. So she has a diagnosis, day 1, of adenocarcinoma, primary unknown, and if you review the phase 3 clinical trials, she has a prognosis of 8 to 13 months, 95% confidence limits. She also has a post-thoracotomy pain syndrome. She's going to be using opioids and adjuvants for the rest of her life. But she does come back to work. And then at 6 months, she's got this large mass in her axilla. My goodness, said the oncologist, probably coming from her breast. Let's give her chemotherapy. She gets cisplatin and Taxol. Sorry, she gets carboplatin and Taxol. Tough treatment. She has full chest wall radiation therapy. She has more chemotherapy, and at 21 months, she still has disease. But what I will tell you is because of, you could hear the therapy's aggressive, yes? Yes. Because of the best of integrated oncology and palliative care, Kit missed only 1 day of work. I can tell you because she was working with me. I wasn't the oncologist. But at 21 months, because of recurrent mass, she made a decision that this treatment isn't working, and she enrolled in our specialized palliative care services. She had 3 months at home with her family, Her oncologist did visit her at home, as well as the palliative care team, and she died 24 months after her diagnosis. Where the median survival would be 1 year, she lived 2. And she saw the launch of our new project, which is the basis of all the curriculum materials that I teach today. So she realized her dream, and she lived the life she wanted to live. In fact, she said goodbye personally to the people she loved when she realized this wasn't going to be successful in terms of more survival. Well, what about that symptom management? Let's go back to our patients. There's Bill. I got to see him in follow-up. He had an incomplete spinal cord compression with incontinence, leg weakness. He was getting about with AIDS. He had a reasonable pain management plan in place that was controlling his pain beautifully. And he asked me, whenever I tell his story, to thank you all for listening to his reality and for giving him back his life. He was now out and about with his buddies with some help. He needed a wheelchair, but he was enjoying life, and there they arrived to raise their glass to honor every doctor and nurse and pharmacist and counselor who helps people live their lives. It wasn't just about the cancer care. He lived multiple months more, because you can imagine prostatic cancer, the disease is often slow. He had an amazing quality of life. And then there was Martha, who you met. Well, we admitted her. Remember, she was the one with 21 hospitalizations in 24 months? Well, we admitted her, and she had shortness of breath. We gave her low-dose morphine, converted her to extended release, but again, it's low dose. Guess what? She was able to go shopping. She was a happy camper. She was schlepping the oxygen, but she was out. And the shortness of breath was managed by the hospice triage team. How long do you think Martha lived like this? This is a organ failure disease. How many of you would say, well, maybe 6 months? How many of you would say maybe 12 months? Anybody want to hazard a guess for 18 months? Although Martha's dose increased, she lived for 2 years after we took her on the hospice program. Ultimately, she never returned to the hospital, ever, in those 2 years. Because there was triage in place. When she got shortness of breath, she called us, she talked to a nurse, there was a doctor supporting the nurse, and we looked after her shortness of breath. As most people do with organ failure, she died suddenly one night, likely of a ruptured aortic aneurysm, completely unrelated. And over to Ellen. I told you that Ellen also, she was the dean of nursing, remember? She'd never even heard of palliative care. She said, my goodness, you're going to give me a prescription for an opioid for breathlessness? It's what she told my colleague, and we said yes. We gave her hydromorphone just because she was allergic to morphine. We only gave her the equivalent of 5 milligrams of morphine, just like Martha. Again, she was taking 6 to 8 doses per day only. Over time, it did increase, so she was up to 30 milligrams each dose. How long do you think she lived? 18 months. She gained her weight back. She always said, well, I walk fast and I talk fast. And boy, was she walking fast and talking fast. Out and about, out to movies, etc. And then in the final days of her life, we were able to keep her incredibly comfortable at home using benzodiazepines to ensure she had no awareness of the terminal dyspnea. She died quietly, and her family was so celebratory. They had so much more life with her and done so much more. And what about Maren? Remember, she was the lady with ovarian cancer from the cancer center, from the NCI. She came in, we gave her an octreotide infusion. Within a very short time, days, her nausea completely settled. her distension went away. She was able to be at home, as you can see, for 4 months with her family, where she thought she was going to die. So I'm only illustrating with a few cases, but can you get my theme? That symptoms and the lack of integration of palliative care can shorten people's lives and make them miserable. Can you see the opportunity for Jaipur? So, one last question for all of you. What do you want your illness experience to be? These are the 4 curves of functional decline. How many of you would say, well, I would hope for curve number 1, the organ failure. Maybe it's the cardiac, or the pulmonary, or the renal, or the liver failure. Who would like curve number 1? Multiple hospitalizations, crises, but here's our wonderful principal able to get you back out on the street, and you'll come back in again and visit him again. Nobody want curve number 1? Who would like the cancer curve? Curve number 3, first line therapy, second line therapy. We could be just down the street, BMCH, right? And we could do wonderful things, and then you'll start to decline, but maybe we have a phase 1 clinical trial for you. Who would like curve number 2, the cancer story? And who would like curve number 3, the dementia, curve number 2, sorry, the dementia story? You know, the slow dwindles and decline, dependence. Maybe this is going to go on for years. Or who would actually prefer sudden death? You are all delusional, aren't you? Which one of your colleagues or your family member is going to allow you to die suddenly? I've got resuscitation for you, don't I? And then you can come to the facilities here or your local hospital, and if you've really had a cardiac arrest, something like that, we're going to intubate you. And are we going to be able to withdraw? I'm hopeful. But not today, right? Most people will not withdraw until you die. And how long are you prepared to wait until I control your symptoms? Days, weeks, months, or how many of you would say the next few hours, please, Frank? Next few hours, right? That's what we all want. So very important that we do that. Well, I'm highlighting all of this because I think this is an opportunity. It's the new wave of modern medicine is to do the integration of palliative care, and I hope you can see the value. People will live longer and better, and you will be more successful at managing their disease. I promise you. And the bottom line is, whatever we set up, good news or the bad news, it will determine the care you get when it's your turn. And for some of you, it may be a surprise and come sooner than you imagined. So my question is, will Jaipur and India be ready for you?
Yes.
Yes? Yes, well, let's do it together. I'm in for it. Walking the walk. I'm hoping that you will find incredible meaning and value and take that next step of applying the art and the science, the new knowledge, the new skills, and integrate it into your practice. And we're all here to walk with you. Because I want you to have the best possible careers and inspire and empower it in others. Namaste for the opportunity to be with you, and I look forward to any dialogue.
Thank you so much, sir, for such a mesmerizing talk on such an important topic. And may I now request all the dignitaries to again come up the dais for the felicitation ceremony. Today, SMS Medical College feels proud to bestow upon the Dr. Farooq Abdullah Award Oration 2023 to Dr. Frank D. Ferris, our guest orator for today. We are indeed proud to have you here, sir, today.
Thank you so much. Oh, my goodness. That was great. Oh, my goodness. Wow. So much. Thank you.
May I now request our ADP Academics, Dr. Monica Jain, to deliver the vote of thanks.
Honorable Deputy Swan Vidays, our esteemed orator for today's function, Dr. Ferris. It was indeed a very enjoyable session for all of us, and the role of early integration in palliative care will be taken care by all of us, in fact. And Dr. Ashwin is doing a wonderful job in the newly laid Department of Palliative Care. And many of the things are already being taken care of, but yes, it is a continuous process of learning. Thank you very much, sir, for being here and accepting our invitation, and congratulations for receiving the award for Farooq Abdullah Oration Award. And I would like to thank all the audience, the guests, Ma'am Salma, Ma'am Anjum, for coming here and gracing this today's oration. And I was already telling you, sir, that this is a combined function of the Farooq Abdullah Oration Award ceremony, plus it is the ongoing Platinum Jubilee Celebration also. So I thank each and everyone who have been here and making this event joyful and colorful. Thank you very much, and I request all of you to please have a cup of high tea outside. Thank you very much.